Welcome to The Explainer. We're getting right into exactly what you need to know about obstructive sleep apnea, OSA, to absolutely crush the MSRA exam. We've taken all those dense textbooks and distilled them down to the absolute highest yield facts, the classic clinical presentations, and crucially, those sneaky legal traps they love to test. So, here's our quick roadmap. We're covering the core features of OSAHS, the management strategy, the DVLA driving regulations, some high-yield exam mnemonics, and finally, a rapid-fire MSRA quiz.
All right, let's jump straight into part 1, the core features of OSAHS.
Now, what's really fascinating here is the specific anatomical mechanism, right? We aren't just talking about, a bit of loud snoring. We are looking at recurrent episodes where the upper airway literally collapses during sleep. It's this collapse causing intermittent hypoxia and sleep fragmentation that actually drives those debilitating symptoms we see in our patients. Basically, the brain has to keep waking the patient up just to breathe, completely wrecking their sleep architecture, which then leads directly to that overwhelming daytime sleepiness.
So lock in this classic clinical triad right now, the 3 S's. First up, snoring, and we mean loud, disruptive, highly irregular snoring. Second is silence. This is usually reported by a very tired, very frustrated partner who witnesses these apnea episodes or sudden choking and gasping arousals. And third, somnolence, that excessive daytime sleepiness we just talked about. If your exam vignette features an obese patient with these 3 S's, your mind should immediately jump to OSHS.
But how do we actually quantify that exhaustion? I mean, we can't just take a patient's word that they're feeling a bit tired, right? We need the Epworth Sleepiness Scale. For the MSRA, you've got to memorize this magic number, strictly greater than 10. A score above 10 officially flags a patient's daytime sleepiness as clinically significant. So if you see a score of 12 or maybe 15 in a prompt, you know for sure you're dealing with a significant, actionable case.
Moving one layer deeper, when you're scanning a clinical vignette, it really helps to hunt for systemic features pointing to secondary anatomical narrowing, specifically macroglossia, or an enlarged tongue. Just memorize the acronym AHAD. A is for acromegaly, where excess growth hormone causes soft tissue hypertrophy. H is for hypothyroidism, causing myxedematous soft tissue swelling. The second A is for amyloidosis, that's protein deposition in the tongue and pharynx. And D is for Down syndrome, characterized by congenital midface hypoplasia and relative macroglossia. Basically, if the exam gives you a sleepy patient with, say, spade-like hands or a history of protein deposits, they are absolutely testing your knowledge of AHAD.
Moving right along to part 2, management strategy.
Getting the diagnosis is really only half the battle. Knowing the exact order of operations for treatment is where you pick up those crucial exam marks. You have to triage your approach systematically. Seriously, don't jump straight to surgery. Always ensure baseline lifestyle measures are addressed first or at least concurrently. We're talking weight loss, side-sleeping positional therapy, and avoiding sedatives and evening alcohol, since those just relax the airway muscles even more. Only then, or in moderate to severe cases, do we escalate to our first-line medical treatment, which is CPAP. And as a backup, we have second-line alternatives like mandibular advancement devices, or occasionally targeted surgery for specific anatomical issues like severe tonsillar hypertrophy.
Notice the distinct mechanical differences here. CPAP is the definitive first-line therapy for moderate to severe OSHS. Think of it as a pneumatic splint. It literally uses air pressure to force the pharyngeal airway open. On the flip side, the mandibular advancement device, or MAD, is an intraoral mouthguard. It physically projects the mandible forward to increase that retroglossal space. This is your go-to answer for mild cases, or, crucially, when the vignette mentions a patient who is completely intolerant to CPAP, usually because they find the mask way too claustrophobic.
Next up, part 3, DVLA driving regulations.
You're going to want to pay very close attention here, because this is a massive, high-yield MSRA exam trap regarding legal duties. Medical examiners absolutely love testing your knowledge of professional responsibilities. Look, if you have a patient with simple snoring or mild OSA, but they don't have excessive daytime sleepiness, they do not need to notify the DVLA. They are perfectly fine to continue driving. But the second that patient has OSHS with excessive daytime sleepiness, the rule flips entirely. They must cease driving immediately and the DVLA has to be notified. Remember, as clinicians, public safety is paramount.
Okay, part 4, high-yield exam mnemonics.
Before we jump into testing your knowledge, let's quickly review this ultimate decision tree. Grouping information like this is exactly how you pull correct answers quickly under that intense exam time pressure.
Mild or asymptomatic patient, your action plan is lifestyle guidance and follow-up, offering that mandibular advancement device if they really need it. But if the prompt describes a moderate to severe case or specifically flags a sleepy driver, your action plan immediately escalates. You must prescribe CPAP and trigger that crucial legal DVLA notification. Connecting the medical treatment directly to the legal duty is exactly how the MSRA is going to test you.
Let's wrap things up with Part 5, the MSRA Rapid Fire Quiz.
Okay, it's time to test your active recall. We've gone over the material, now let's actually apply it. Try to mentally lock in your answers before I reveal them. Let's see how much you've absorbed. Question 1. What is the first-line definitive medical treatment for a 52-year-old obese man with an Epworth score of 16, so severe OSHS? The answer is continuous positive airway pressure, or CPAP. Notice how an Epworth score of 16, which is well over our threshold of 10, automatically points straight to CPAP. All right, question 2. An OSHS patient displays frontal bossing and spade-like hands. What is the underlying endocrine disorder? That would be acromegaly. Those classic facial changes and hand hypertrophy point directly to it as the cause of that soft tissue macroglossia.
Moving on, question 3. Aside from acromegaly and hypothyroidism, name 2 other medical causes of macroglossia that predispose someone to upper airway collapse. The answers are amyloidosis and Down syndrome. This pulls right from our AHD mnemonic, rounding out the A and the D. Question 4. A patient with mild OSHS finds CPAP completely intolerable due to claustrophobia. Which oral appliance can you offer them? You offer the mandibular advancement device, or MAD. This just reminds us that the MAD mouthguard is the specific rescue alternative for those CPAP-intolerant patients.
Question 5. A commercial driver has moderate OSAH with sleepiness affecting their concentration. What must they legally do? They must cease driving immediately and notify the DVLA. Remember that exam trap. Question 6. Above what numerical score on the Epworth Sleepiness Scale is somnolence considered clinically significant? The answer is strictly greater than 10. That magic Epworth number is the absolute trigger for classifying daytime sleepiness as a significant clinical and safety risk.
Question 7. What anatomical event occurs repeatedly during sleep to produce apnea in OSHS? The answer is the collapse of the upper airway, specifically due to the loss of pharyngeal dilator muscle tone during sleep. That's the core pathophysiology you absolutely need to know. Question 8. A patient presents with loud primary snoring, but they have absolutely no daytime sleepiness. Do they notify the DVLA? The answer is no. Remember, if it only causes snoring without any sleepiness, the DVLA is not involved and they can keep right on driving.
Almost done. Question 9. What specific non-pitting soft tissue swelling occurs in the tongue and pharynx of hypothyroid patients? The answer is myxoedema, which is the accumulation of mucopolysaccharides. Definitely watch for this specific term in hypothyroid vignettes. And finally, question 10. Under what clinical condition will the DVLA actually permit a driver with treated OSAS to resume driving? The answer is when symptom control is medically established and treatment adherence, like providing actual CPAP usage data, is confirmed. They don't just get their license back automatically, they have to medically prove their compliance.
And there we have it, the high-yield facts, the mechanisms, and those crucial medical legal rules. But, it leaves us with a pretty critical real-world question. With so many mild cases going completely undiagnosed, how many drivers are currently on the road right now, right on the edge of slipping into severe, dangerous somnolence? Keep that in mind next time you see a sleepy patient on the ward. Thanks for joining this explainer.